So, welcome to Bridging Oral Health and Non-Communicable Diseases, a podcast from the World Federation of Public Health Associations. I'm your moderator, Leonie Short, and today we're exploring a critical but often overlooked connection in public health, the bidirectional relationship between mental health and oral health. This is episode 5 of our podcast series, where we examine how oral health connects with different non-communicable diseases. In our last episode, we discussed the important links between oral health and diabetes. Today, we're diving into the interplay between mental health conditions and oral health outcomes. Now, as an introduction, mental health disorders affect over 970 million people globally, with anxiety and depression being the most common conditions according to the World Health Organization. The COVID-19 pandemic has further worsened this crisis, with a 25% increase in global prevalence of anxiety and depression. What many don't realize is that mental health and oral health share a profound bidirectional relationship, each significantly impacting the other. Research shows that people with severe mental illness have 2.7 times higher risk of tooth loss compared to the general population. Conversely, chronic oral pain and dental problems can trigger or exacerbate anxiety and depression. This connection has major implications for public health systems, particularly in integrated care approaches. Today, we'll explore these connections and discuss what public health providers can do to address this intersection of mental and oral health. I'm delighted to be joined by two distinguished experts who bring unique perspectives to this important topic. First, we have Dr. Bibhav Acharya, a professor of psychiatry at the University of California, San Francisco, and the founding director of the UCSF Psychiatry HEAL Fellowship in Global Mental Health. Born and raised in Nepal, he attended Haverford College and Yale School of Medicine on full scholarships. He has led several programs integrating mental health into routine services, including advising the World Health Organization in testing the collaborative care model. With funding from NIH and philanthropists, he has led multiple studies, including 4 current large intervention studies on mental health, domestic violence, non-communicable diseases, and digital health. His recent book, Global Mental Health Training and Practice, an Introductory Framework 2024, draws from the expertise of more than 70 global collaborators to create a comprehensive guide for working across cultures and contexts. He co-founded Possible, a healthcare innovation non-profit that has administered over $40 million in healthcare programs in rural Nepal. For his global health work, he has received the Thomas N. Burbridge Award for Public Service and the Leonard Tao Humanism in Medicine Award. Welcome, Dr. Bibhav Acharya.
Thank you so much for the kind introduction and the welcome. Looking forward to sharing what I know and learning from others.
Our second guest is Dr. Maha Tantawi. Dr. Tantawi is a professor of dental public health at Alexandria University, Egypt. Her research focuses on the oral health of underserved populations in Africa and the Middle East, especially young children, in addition to the use of technology to support oral health promotion and disease detection. She's secretary of the Oral Health Network, the e-Oral Health Network, and a member of the Global Oral Health Inequities Research Network, for the International Association of Dental Research. She has led several research projects focusing on low-cost solutions to prevent caries in young children in rural areas and has received the 2025 IADR Women in Science Network Award for Distinguished Female Mentor, for which she was nominated by her mentees, young women researchers who have already received international awards themselves. She co-founded the Africa Oral Health Network, the AFRONE, whose mission is to build the capacity and mentor early career researchers working in oral health in Africa. She is also a core member of the Early Childhood Advocacy Group, whose research has contributed to the global focus on caries in young children. She is the senior board member at M.Sc Oral Health, a leading journal in the field that contributes to shaping the discourse on oral health, especially in low and middle income countries. Welcome, Dr. Tantawi.
Thank you very much for the introduction and the kind words. It's a pleasure to be here and looking forward to our discussion. Thank you.
Thank you both for joining us. Now let's begin our discussion. Now, the first question, Dr. Tantawi, can you explain the relationship between mental health and oral health? And what are the key biological and behavioural mechanisms that connect these two areas?
The connection is between oral health and mental health is bidirectional. This means that poor mental health can lead to poor oral health and vice versa, creating a vicious circle. Even without disease, when we're talking about everyday life, like we grind on our teeth or bite our nails or lips to release stress or cope with anxiety. So the connection is there and evident. We can think of this connection as being driven by biological and behavioral, in addition to maybe biopsychosocial mechanism. The biological mechanism that goes both ways from mental and between mental and oral health, we talk about medication side effects. Psychotropic drugs that are used to treat antidepressants and antipsychotics also can cause dry mouth, which is known scientifically as xerostomia. This reduces the flow of saliva, which decreases the protection against tooth decay and infections. There is also another biological mechanism which affects the hypothalamic pituitary adrenal axis, causing dysregulation. Chronic stress from mental illness leads to the dysregulation of this axis, which increases susceptibility to periodontal disease. The biological mechanism actually works the other way around, like from oral diseases to mental health. Like systemic inflammation caused by chronic periodontal disease releases inflammatory markers. These inflammatory markers are the reason for many of systemic disease, and they can, in this case, exacerbate depression and anxiety. Even the oral microbiome dysbiosis can also influence the gut-brain axis, promoting neuroinflammation and others. So this is the biological mechanism. What we may readily think of, however, maybe the behavioral mechanism, which affects oral disease caused by mental issues, like people with mental problems have been known to neglect oral hygiene, either because of depression or any other disease, reducing the frequency of brushing and flossing. You also have people with depression experiencing cravings for sugar products and sort of like reducing the value of their nutrition, which increases, of course, the risk of dental caries. Mental conditions may also be associated with the use of alcohol and tobacco, and we know that these are risk factors for gum disease, periodontal disease. People with dental anxiety also and phobias may sort of like ignore or avoid dental visits and seeking care they may visit the dentist after the condition progresses too far and treatment becomes complex and costly. And there are also things that people with an anxiety may resort to, like bruxism, which is teeth grinding or clenching. This leads to impact on teeth, like enamel erosion, and it also affects the jaw joint, the TMJ, the temporomandibular joint. It also goes the other way around, where oral health affects mental health, like if people have aesthetic problems, of oral disease affecting how they look, like missing teeth, discolored teeth, misaligned teeth. This may lead to embarrassment, social isolation, and anxiety. Loss of function also, problems with eating or speaking due to caries, or loss of teeth affects maybe older adults especially, and leads to social withdrawal. They are less likely to interact with their peers and friends, so on. So there are several mechanisms that may explain this association, and there is many aspects to it.
I didn't realize there were so many biological and behavioral mechanisms. Thank you so much for explaining that so well. Now, the next question is to Dr. Acharya. Which populations are most vulnerable to poor oral health due to mental health conditions? And the second part of the question is, how do factors like medication side effects, health behaviours, and access to care affect these risks?
The response from Dr. Tantawi was really comprehensive and sort of gave you the lay of the land. So I'm going to try to sort of plug in a few places that I think are worth highlighting, sort of in addition to that. Starting out, like with any kind of health problem, right? So the biggest driver often is poverty and social marginalization. That worsens all health, and oral health and mental health are particularly susceptible, I would say, because they're still traditionally, these two conditions are still seen as a luxury rather than like a fundamental part of a package of care that everyone should get. And so that's a big driver, just being poor and socially marginalized. I think that makes you vulnerable and increases your risk of having problems with both. In mental health, we often, again, broadly classify conditions as severe mental illness and common mental health conditions. So common mental health conditions would be depression, anxiety, and so on. And what's traditionally called severe mental illness is often has sort of, psychosis as part of it, so schizophrenia, bipolar disorder, and so on. And the risk for having oral health conditions is really high among people with severe mental illness. They're more often likely to lose a job, lose insurance, living in the streets, more likely to use drugs, more likely to be in prison, and have, tooth loss and untreated decay and just overall poor access to care. But there are a few other things that sort of make them more vulnerable. Dr. Tantawi mentioned tobacco as a sort of important health behavior that drives oral health and other health as well. One thing worth noting is the worldwide trend of tobacco use has actually gone down, which is a really good thing, except for one population, which is people with severe mental health problems. And if you track for decades, that number has sort of stayed stable. And again, that gives you a signal of how marginalized this population is. The other sort of risk factor, I would say, in terms of medications, are the ones that are often used in low resource settings, so SSRIs, like the classic sort of Prozac and so on, have replaced some of these older medications called TCAs, like amitriptyline and so on. But these medications, the TCAs, are still used very frequently around the world, and their risk of some of the issues that Dr. Tantawi mentioned are actually very much higher than these new medications. So dry mouth tends to be a huge problem with amitriptyline, and it's prescribed very commonly for everything from insomnia to unexplained chronic pain to depression and anxiety, also headaches, but it's a very commonly prescribed medication. And some of the older medications, again, tend to have a worse side effect profile, but they're cheaper. So again, going back to the idea of if you tend to be poor and excluded, the risk is higher. The one last thing I'll mention about risk factor, again, from a systems lens, is that if you end up living in a place where there's a huge separation of oral health and the rest of health, that is a risk factor. And this happens very often. Your insurance is different, the providers is different. A lot of medical doctors will have gone through a general medical training, but I know very little about oral health because I did not go to dental school, right? So this separation, it's good because it helps people specialize, but the downside is there's a huge lack of sort of, exchange and easy access to both services. So the more separation you see in the system, inevitably you will see poor access and cross access among the patients.
And it was really good that you brought in those social determinants of health and the upstream factors, as well as talking about the manifestations that you see. And I did not know that the rate of smoking with people with, I think, severe mental illness was still high. I did not know that. Thank you. Now, the next question is about clinical manifestations. So, Dr. Tantawi, what are the most common oral health manifestations you see in patients with mental health conditions? And how do conditions like depression, anxiety, and eating disorders specifically impact oral health?
If you're a dentist, maybe some oral manifestations should ring a bell, or even the collection of these manifestations may be ringing many bells at the same time. If drugs or medications are a problem, like Bibhav had just said, in some locations, especially the dry mouth, which is common, and dry mouth has implications. You tend to see caries, especially like root caries, which is most affected by the dry mouth because there isn't washing of the products around teeth. You'll also see, of course, gum disease like gingivitis or periodontitis, because of the dryness and because of the neglect of oral disease. Coping mechanism we talked about earlier, these tend to be more seen with anxiety and stress. So you have bruxism, which affects the jaw joint, the TMJ, and it also affects the teeth. You tend to see teeth with worn off surfaces. If we're talking about the effect on soft tissue, there is more fungal infection because of the dryness. There is more ulcers, like aphthous ulcers, because of the stress and anxiety. If we're talking about people with with eating disorders, there is acid all the time pouring into the oral cavity through the vomiting, and this tends to dissolve teeth. So you have erosion and also effects again on soft tissue. So there are multiple actually manifestations. Some diseases have specific manifestations, like depression causes less tendency to perform oral hygiene as it should happen, with all the impact of reduced oral hygiene on caries and periodontal disease. You have also with depression the behavioral factors, which is increased smoking, increased sugar consumption, which leads to several oral disease, but these patterns are clear with depression. And anxiety, again, you have the grinding, the effect of reduced tendency to seek care because they are stressed. People are stressed, especially in extreme anxiety. And we're talking about dental phobia, where it becomes very difficult for patients to seek or to visit the dentist, even though they have problems. So multiple manifestations, sometimes clustering together with different types of mental disease.
Dr. Acharya, how can oral health professionals help identify mental health concerns and vice versa? And the second part, what screening tools or approaches would you recommend for integrated care settings?
I think they should listen to this podcast first so that they understand how important it is, because that's the first part. We can give people all sorts of tools and trainings, but they first need to be convinced that this is important, right? And that goes for both mental health professionals and oral health professionals. And I think the data is very clear that this is important. And now that you've convinced yourself this is important, like, what do you do, right? So I think in terms of screening, so let's start on the sort of what oral health professionals can do. The simplest screening tools, I would say, that have been used, all over the world, often by sort of non-mental health professionals, to screen for things like depression and anxiety. For depression, there's a screener with 9 questions called PHQ-9. It's probably the most commonly used. Again, it's not a perfect screener. No screener is perfect, but it's easy to use. The questions are easy to ask. And if someone's really rushed, you can actually just ask the 2-question version of it. There's a PHQ-2 that just asks the 2 most important questions. And then if you see someone is positive in any of those, then you can ask a longer set of questions and then refer. And similar to that, there's a GAD, which looks at anxiety questions. So it also has more questions, but you can start with 2. So there's a GAD-2 and there's a PHQ-2. So these are 2 simple tools that really take minutes to administer, and they pick up likelihood of having depression and anxiety. And one caution I would say, there's 2 cautions I would say, is that these tools are, especially the anxiety tool, it will not pick up avoidance. And avoidance is really important. And what I mean by avoidance is I can have all sorts of phobias. I could be scared of heights. I could be scared of crossing bridges. But if I have reorganized my whole life to not do any of those things, like if I see that I'm gonna get a job at a tall building, I just don't go to the interview, right? So that way I don't feel anxiety because I've been avoiding all these things. And that's something we need to pay attention to, that a lot of people may not even go to the dentist at all because they have a phobia, right? So if you ask, are they anxious? They will say they're not because they've been avoiding the things. It actually becomes important to not just ask about presence of anxiety symptoms like, feeling on edge or feeling nervous, but also remembering that avoidance is a symptom of anxiety, which brings me to the non-oral health people who are more likely to see patients who actually should go see the dentist, but they're avoiding them. So I just want to put that plug in that we need to be asking, have you gone to the dentist recently in the last year? If the answer is no, then that could actually be because of anxiety and phobia. And oftentimes in depression, I had a patient who just would not go to the dentist. They had depression and anxiety, and they were convinced that if I go to the dentist, they'll find something terrible. It's going to be cancer, and my whole life is going to be upside down. And that's classic avoidance. You have convinced yourself that something terrible is going to happen, and because of that, you avoid healthy behaviors. So that's something that oral health professionals need to do. So that's the first caution, thinking about avoidance. The second caution is it's important to screen, but it's equally important to connect to treatment as well. Right? So, and otherwise, it really becomes unethical. You ask someone questions, and they tell you something's wrong, and you have nothing to offer to them, right? The ideal scenario would be co-location, but at the very least, some kind of clear handoff or clear referral that is going to be essential to go along with screening.
Thank you. And of course, that clear and simple referral is difficult when we have health systems. I think you said before that we're in different silos, so that makes it even more difficult, doesn't it? Yeah. Okay, thank you very, very much. Now, Dr. L. Tantawi, what practical steps can public health systems take to better integrate mental health and oral health services? Can you share any successful models or interventions, please?
Well, let's think of the continuum, like the pipeline, like how things start and how they progress. At the education stage, the very important point, which was raised just like by Bibhav a minute ago, everybody learns in separate spaces in their own worlds. They do not talk to each other. And there is very strong emphasis in health professions educations these days on interprofessional engagement, interprofessional education. And this is very useful if people get educated together, if they share sessions, placements, things like this. This will introduce them early on to the other worlds. A co-location also works. If they work in the same place, it would be easier for them to sort of like ask the patient to, why don't you go visit Dr. X who's just next door? The patient will not have to schedule another visit, to travel to with the cost of travel, with the time of work, with stuff like this. So this also helps. The community, if you go into the community and sort of like spread the word, talk to people about how the both worlds are connected, how oral health and mental health is connected in the same setting, in the same approach, in the same message, same person. This connects automatically the issues and integrate them in the mind of the population. You also have the infrastructure itself. If you plan together to change policies so that they allow integration, they allow screening for mental issues in dental settings, and the other way around, screening for oral health issues in mental settings. These kind of policies and programs integrate automatically from by design. Same for funding. If we like work on research projects or community projects that include both kind of problems in the same solution, this will work. And these things have been tried. There are healthcare systems in the world where this kind of co-location, this kind of shared service provision occurs. Like, for example, when you think of maybe like an example from Africa of HIV care, where there is this one-stop clinic where patients come and they get screened for this and that and this. And it is a very important point that Bibhav had raised. If you tell them that they have an oral health problem, a dental problem, they have caries that needs to be filled, but they do not get care, this is not helpful. It is just one more thing to worry about. So this kind of thing exists. Also, if you integrate the provision of dental care into the overall care of people with severe mental illness, whether they are hospitalized or in their care facilities or stuff like this also brings the oral health issue in the mental care process. So lots of points for opportunities for integration, and I think every setting, every healthcare system needs to adapt to the available resources, to the priorities, but coupling them together would be the most important thing in any way possible to happen.
Thank you. Something for us to work towards. Now, the last question to Dr. Acharya: what key messages should public health professionals take away about this connection? And secondly, how can we better support communities in addressing both mental and oral health together?
I'm imagining if I could talk to everyone at the same time about this, like, what would I say, right? So I think we made a pretty strong case today that the connection between oral health and mental health is very strong. They're intricately connected. It's bidirectional. One worsens the other. I think there's this perception of it being mostly aesthetics, and it's there. Like, if your teeth are a certain way, I can imagine the impact on confidence and social anxiety and so on, and that's there. But it's not just that, right? So that it can lead to a lot more sort of serious, life-altering health problems. So I think thinking about it not just as like an aesthetic thing, but like a serious health issue. That's the first part. And then not only is it important, it is fixable. Like we've talked about these models of integrated care, co-located care, or at least a warm handoff. These tools exist to track people and screen them and then connect them to care. Again, the practice may be difficult. There's a tool called I remember seeing called OHAT, and for non-sort of dental professionals. And I look at it, and it's a mix of things that you ask the patient about their experience and some examination that you have to do. And so I imagine trying to examine a patient in the middle of a mental health interview for their teeth. It's actually very difficult to do that. I can ask how they feel. And oftentimes I'll say, does your mouth feel drier? That's easy to ask. It doesn't require me to look at it. Because if I look at it, I need to know what a normal mouth looks like. And then is it too much, too little? That requires a lot more experience that I just don't have. So I think focusing on tools that are simple to use, that ask patients about their experiences, and then quickly connecting them to a professional who can actually take a look and not only sort of decide what's going on, but also say it clearly. Here's what's going to happen, and here are the next steps. Because a lot of fear about oral health comes from, I'm going to be in pain. Or what kind of crazy things they're going to do to me. They're going to pull out my teeth, and I'm going to look different. So all these worries, a professional will be able to say, no, here are the options, and here's how we're going to manage your pain, and so on. And then of course, the focus on equity, who's at the highest risk, and making sure we focus on them. At the systems design, sort of the public health, design perspective, making sure that you have the right incentives that prioritize equity, right? So a simple example would be how people are paid. So at the hospital where we had a dentist, she was salaried rather than being paid by volume. And again, it has pros and cons to both of those. But if you get paid by how many patients you see, are you going to sit down and spend 30 minutes reducing someone's anxiety and helping them sort of ease into it? Or are you going to say, you know what, come back when you're ready, because I have 10 other patients who are ready to go right now. And so you need to pay attention to the incentives you have in the system, because that will affect clinician behaviors. So maybe if anyone has a severe mental health problem, they need to get not just tobacco cessation, but also a visit to a dental health professional. So that's a metric. If anyone's prescribed a medication that we know has these side effects like bruxism, or which is like worsening teeth grinding, or sort of dry mouth, then they need to be tracked to make sure that they're seeing the dentist. So I would say big picture, right? So create these incentives for the system, while at the same time train and support the individual practitioners so that they have the tools they need to both screen and connect people to care.
Well, thank you very, very much. Now, to wrap up, I'd like to give each of our guests a moment for final thoughts. So, Dr. Tantawi, what's the one key message you'd like our listeners to remember?
Make every encounter counts, like use the time you have with the patient to look at the patient, not at their teeth, not at their mental health, not at their stats. The patient is a human being, so think of them as a human being. Ask about things that stick out, and make room for this in your daily routine. This is important.
That's a wonderful message. You'll make a great psychiatrist. Pay attention to the person. I would say, sort of reiterate, really, both mental health and oral health, they're not luxury items. These are essential for quality of life. These are essential for health. We got to pay attention to marginalized populations. And I think mental health has actually gotten a lot of support and advocacy, and oral health needs to sort of get the same thing, especially together, because I think the more we integrate, the more better outcomes are going to be.
So thank you so much, Dr. Acharya and Dr. Tantawi, for this enlightening discussion. The connections you've highlighted between mental health and oral health are truly eye-opening and underscore the need for integrated, holistic approaches to healthcare. To our listeners, healthcare workers, public health specialists, and community advocates, we hope this episode has provided valuable insights into the mind-mouth connection. Remember, addressing oral health is addressing mental health and vice versa. By recognizing these conditions, we can develop more comprehensive, compassionate, and effective public health interventions. If you found this episode valuable, please join us for our next episode, where we'll explore the connections between oral health and non-communicable diseases, patient voices. This podcast has been created by the Oral Health and Non-Communicable Disease Work Groups at the World Federation Public Health Association. Thank you.